Tēnā koutou katoa. Ko Ana Sokratov tuku ingoa, ko Ngāpui, ko Ngāti Bulgaria, ngā iwi. Ordinarily, I'm the consumer consultant for the mental health services group at Waitemata DHB. However, in the last year, I've also been leading a national project on behalf of the Mental Health Commissioner, which you can see there is titled Making a Difference for Rangatahi, specifically looking at Māori youth. And apologies from Hori Kingi, our cultural advisor. He had to go to a tangi, and while I'm working at Waitemata and being shared with the Commissioner, Jared was working at the Commissioner, is now working at Waitemata DHB, so that's why he's not here. Anyway, there'll be more. So this is just an introduction. We used, the previous one was, we presented this work at a transcultural mental health conference last year in Perth. So Hori Kingi has provided us with this whakatauki to introduce the work. Basically, this presentation looks at these points. Why focus on Māori Rangatahi? What is the Whare Declaration, its principles and alignment with this project? What our project overview was, what were some of our first impressions and next steps? So why Māori Rangatahi? So there you can see we've got increasing prevalence of mental illness, substance use and suicide among Rangatahi, and a disproportionate prevalence amongst Māori. The prevalence is higher for Māori, and Māori are less likely to access or visit mental health services. Māori Rangatahi are more than have twice the risk of suicide. There's the consideration of socio-economic deprivation, which is linked to the incidence of mental health problems. Māori in New Zealand are more likely to live in deprived areas. And Māori have a younger population demographic, which is really the crux of why we need to do something soon. So 43% of the total Māori population in New Zealand is in the 0 to 19 year age bracket. And Māori infants and children and adolescents make up 24% of the total New Zealand 0 to 19 population. So the Whare Declaration, what that is about is it supports Indigenous leadership within communities in the healthcare workforce. It recognises the protective power of culture and the need to integrate clinical and cultural models of care. It was developed in 2009 and it originated out of an international conference that began some years ago called the International Initiative for Mental Health Leadership. This particular conference has an strong Indigenous component to it. And the Indigenous representatives, as you can see, come from New Zealand, Australia, Canada, and America. And they put together this Whare Declaration, and which was given a promise of support by the New Zealand Mental Health Commissioner in 2013 at the last IML conference. Okay, so it's a leadership framework that promotes and incorporates the connection with culture as a pathway for positive health outcomes and wellness. We often think of that as whānau ora in a New Zealand context. It requires services and practitioners to be culturally competent and safe. This is important in the context that often the cultural background of the provider is relevant to the outcomes that are achieved, and also relevant to our need to grow and develop our Māori health workforce at all levels. It supports evidence-based practice, that is evidence-based clinical practice and evidence-based cultural practices, looks to informed, credible, strategic Indigenous leadership at all levels, who can provide their influence through the networks they have. So, as a consequence of some of that information that I've just given to you, the Commissioner decided that this would be an area that she'd like to give some focus to. in general, the aims of the project were to promote improved health outcomes for rangatahi, identifying and sharing the things that services and people in services are doing that are working well, and how can we share that with the sector, and also to talk to services about where were the common areas of challenge and barriers in their ability to provide services to Māori youth. So, as a consequence, at a high level, in keeping with the Whare Rata framework, the HDC, Mental Health Commissioner, established a high-level partnership arrangement with Te Rau Matatini, who are the Māori Mental Health Workforce Development Agency, and Hori Kingi is a member of Te Rau Matatini, so he acted as our cultural advisor. There was Jay from the Commission, and there was me leading this whole project as a consumer, or tangata whai ora. And it also kind of facilitated the relationship because I'm on the board of directors for Te Rau Matatini, but if you're going to do a piece of work that is about Māori, it needs to be led by Māori and supported by Māori in the sector. So what we did, we identified services which were recommended to us through our networks that we would go and see in the sector. We have seen more than eight sites, but essentially we've covered DHB, NGO, mainstream and Māori, rural and urban, AOD, mental health, sexual health promotion services. So being willing to look at other services and what they might be doing that we could take some learnings from. Now, what you don't see there is that at the beginning of this year we went to the South Island. So we've been up to Northland, we've been to Tairawhiti, we've been to Rotorua, Whangarei, Auckland, Hamilton, Nelson, Marlborough, Christchurch and Dunedin, and I did a phone interview with the service in Invercargill. But essentially it was looking at the population demographic as well, where are the majority of Māori living. So some of our first impressions, and I'll give you a little hint because this presentation was actually put together in October, so a lot more has happened since then. But first impressions were that services in the areas were impacted significantly by persistent socio-economic challenges in communities. Talk about Northland, talk about Tairawhiti. And it's come up today in the talk in the discussion group, contracting models and requirements. You've got fragmented services because of funders funding multiple providers. You've got gaps in services because, as we've heard today, some age groups are in service, some age groups are out of service, and this is replicated around the country. Clearly everyone's talked today about the workforce shortages that we've got in CAMS mental health, CAMS AOD and the youth workforce primarily. I want to pose a question because there will be a report coming out of this, but my question is what is the role of workforce centres in supporting the development of the workforce here? They're called workforce centres. One would like to think there was a higher expectation from the sector about what those workforce centres were delivering to the workforce. So that's three of them, four actually, but Wiri, Matuaraki, Te Rau Matatini and Te Pou have a role in the solution to the problem. I'm also going to signal what is the role of professional bodies, because one of the key things that we need to be thinking about with our hard-to-reach rangatahi and whānau is the need to have a level of cultural competence across all of the people working in our workforce. So, for example, the College of Psychiatrists have provided some leadership in this. They've moved to a competency-based framework, and they now have a requirement as part of the fellowship training that there is a meeting of cultural competency within their training, okay? So it's being done, it can be done, I know because I made it happen. And so there's a role there. And what do workforce centres then do in supporting that? The other thing, people often resort to tertiary institutions. Yes, they are one source of the workforce, but they're not the only source. And we have a clinical and a non-clinical workforce, and we need to address the needs of both. And of course, you've got, people have talked about policies today that get in the way of what you need to do that you know is effective, so that we have organisational processes and structures getting in the way of our need to be able to sustain and grow a Māori clinical and culturally competent workforce, and that's the same for a mainstream one. What were some of the strengths that we saw which were really significant? Because believe it or not, it's not all bad news. There's some really amazing people out there. I just want to acknowledge you all, to those in the room who I met with and those who aren't here today. Amazing stuff. I told my CEO, because I got to present to his peer review group this work, and you know, Waitemata DHB, bells and whistles for everything, right? And I just said to him now, after being around the country and seeing people go without an internet connection or networks or cars or anything, or not even enough people on the ground, and huge need in their communities, and they're just doing it. And so I have no tolerance, as I told my CEO, for people in Waitemata who say they cannot do their job because they haven't got the latest bell or the newest whistle. Okay? I think there's a balance that we need to arrive at again in terms of workforce expectations about where the money's best applied and what it's best used for. So strengths, a lot of services, including mainstream services and one DHB, had adopted Māori protocols, Māori philosophies, Māori values, in both the philosophy of their service, the way in which they worked with people, and the way in which they engaged with Māori. Engagement's an important one. There was really amazing Māori leadership and services that we saw. We did see the Māori workforce we did see was strong, committed, clinically and culturally. There was the use of cultural interventions and processes and care. A lot of them were moving, now that we actually have a formal policy that permits you to work with families in a meaningful way, called whānau ora, so they were embracing the opportunity to go in that direction. Everyone had a strengths-based approach to building resilience in young people. And of course Rangatahi leadership, and we saw that emerging in a number of ways where some Māori providers in the South Island are growing their own. Young people who are looking for work, they're taking them on, they're developing them on the job as a strategy to try and get some numbers on the ground. So a lot of creativity out there as well, and I think we should pride ourselves on that in mental health and AOD. So there you go, you've got what are the key strategic documents in this area, those two which are part of the context that we operate in now. Where to from here? So I gave the Commissioner a draft report on Monday, and I've got a meeting with her on Thursday, so I'll tell you after that. No, there will be a report that's published, and we're pushing to make it by the end of the financial year that it'll be out for publication. Just wanted to say something lastly about the conversation and the discussion you had before, is we all like convenience, and it isn't all on an iPhone or the internet. Sometimes it's being able to go to one place and get everything sorted. So be mindful of that when we think about hanging on to what we've always done, because that's the way we've always done it, and think more broadly about what are the solutions and how can we work with the other agencies in that positive outcome, which is about flourishing youth population, but also, through individual flourishing, families flourish and communities do too. So, thank you.